If your quest for longevity feels overwhelming, here's some good news. It starts with one simple daily habit. MitoPure gummies from Timeline. They're the first ever longevity gummies that ignite mitophagy, your body's natural anti-aging pathway. MitoPure is a clinically validated solution backed by over 15 years of research. MitoPure gummies utilize a powerful compound that redefines what's possible for your longevity. MitoPure produces the first ever urolithin A gummies that support your cellular energy so you feel strong, clear, and vibrant. Boost your cellular energy and enhance muscle strength and endurance, all without changing your diet or exercise routine. As someone who loves to stay active, I've noticed a significant boost in my workouts since I started using it. I feel stronger and more energized, and my recovery time has improved dramatically. Better recovery starts at the cellular level. For more information and to order, just go to timeline.com/Hoffman. Use coupon code Hoffman at checkout for 20% off. That's timeline.com/Hoffman for 20% off MitoPure gummies with code Hoffman. Welcome to today's Intelligent Medicine Podcast. I'm your host, Dr. Ronald Hoffman, particularly looking forward to today's Intelligent Medicine Podcast. Not that I don't always look forward to my Intelligent Medicine Podcast, but I get to talk to guests that we've frequently interviewed here on Intelligent Medicine, who I have tremendous respect for. He's Gary Taubes, author of a new book entitled Rethinking Diabetes. And for those of you who don't know Gary Taubes, because he is a very big deal in the low carbohydrate movement, very influential. And if you may remember, a very pivotal article in the New York Times Magazine. I remember it like today in 2002, on the cover of the New York Times Magazine appeared a picture of a big, juicy porterhouse steak. And what it was, and the headline was, "What if it's all been a big, fat lie?" Play on words, intentional. Subsequently, he's written now 6 books, including the bestsellers Good Calories, Bad Calories, and Why We Get Fat. Also, most recently, prior to this book, The Case for Keto. Gary Taubes is a journalist, but he is also a big history of science guy. And that's why this book is special, because it really is a most remarkable book in that it lays out the history of our approach to diabetes from classical Greek and Roman times up until the Enlightenment, to some of the early low-carb thinkers who subsequently were pushed aside by the prevailing viewpoint that fat is bad. And he's going to tell us a whole lot about the evolution of our thinking about the relationship between diet and diabetes. Gary, welcome to the program. By the way, congratulations on the book. And I have to say, your book is reminiscent of a book, one of my favorite books, which is The Emperor of All Maladies by Siddhartha Mukherjee, which is a comprehensive look at cancer, a big undertaking. And you've done the same for diabetes, in my mind, in your book, Rethinking Diabetes. So kudos to you.
Well, yeah, thank you. And I got a nice endorsement from Dr. Mukherjee as well. What's interesting is, when you do a history of a disease and you mostly conclude that the conventional thinking, or you don't challenge the conventional thinking, then the book gets widely accepted as a history of medicine text. If you do it as I do, and it's a critical assessment of the thinking as the years go by, it's much more difficult to get the historians of medicine, the journalists, to pay attention, because now you end up arguing that one problem with medical science is we often make mistakes. That's why medicine was always considered an art until roughly the 1970s, when the evidence-based medicine movement began to arise. So anyway, thank you for having me.
Oh, it's my great pleasure. And by the way, and I'll quote the the blurb from Dr. Mukherjee, who writes about rethinking diabetes. One of the crucial responsibilities of scientists and science journalists is to question established beliefs and common assumptions. Gary Taubes accomplished precisely this in this thought-provoking book. So, Gary, trace us back to some of the origins of thinking about the relationship between diet and diabetes, and then where did we take a wrong turn, and why was that?
Well, so let me digress also. Just to say the reason I started my career as a journalist, my expertise and my interest has always been good science and bad science and controversial science. You become a scientific historian when you do this kind of work because you have to understand the evidence base of whatever arguments that you're discussing, analyzing. And so you have to go back in time to see, in effect, why we believe what we believe. In diabetes, I ended up going back to 1797, which was when the first claim was made that this was a disorder that could be kept under control. And it was a British physician named Rollo who was treating, he was a British army physician. He was treating a British colonel who had showed up with diabetes. He assumed that it was a disorder where this fellow couldn't metabolize the grains and sugars in his diet, and that's why sugar was showing up in his urine, which was how you diagnosed diabetes back then after the more severe symptoms of the disease showed up. And he put this fellow on what would eventually became known as the animal diet, which was fatty meat and green leafy vegetables and nothing else. And Meredith got better. And in fact, Meredith, who was on a path to die within a year or two, lived for another 12 years. And Rollo wrote a pamphlet about it. And he said, look, he saw another patient, a general, who also improved on the diet, but then fell off the diet, as people often did. He wrote a pamphlet saying, look, I think I found a treatment for diabetes, which had previously been considered an incurable disease. It was a rare disease, but an incurable one. And he circulated the pamphlet throughout the United Kingdom, and he asked physicians to write in and say, try my approach, see what happens. And a few dozen physicians wrote in, and he published their responses. And the gist of it was that this animal diet seems to work, that if you don't feed a patient with diabetes what we now call carbohydrates, so starches, grains, sugars, the patients, for the most part, don't manifest the symptoms of the disease. And this became the standard of care through the 19th century. So every major diabetes specialist in the US, in the UK, in Europe, advocated this way of eating. The most influential Italian expert would actually lock his patients away for a couple of months so that they couldn't eat anything but animal products. And then when he knew that they were essentially cured, he would let them out of lockdown. This standard of care was maintained until 1921 for the most part, until when insulin was discovered. Mm-hmm. So by 1921, it was believed that all diabetes was a disorder of insulin deficiency. It was some kind of pancreatic deficiency. The researchers at the University of Toronto managed to isolate the hormone responsible. They eventually called it insulin. And in January 1922, they initiated insulin therapy, and they took a young boy, 13 years old, who was essentially on his deathbed, emaciated, and so close to death that they were willing to, parents and the boy were willing to say yes to this radical experiment that he get the insulin therapy. And within weeks of finding a effective dose, the boy had been returned to health. And within a month, they published a paper about this kid and 6 other cases. And from then on, despite the best efforts of some of the leading diabetes specialists at the time, dietary therapy became an adjunct of drug therapy.
Mm-hmm. So the paradigm switched, because prior to insulin, the only recourse they had to tweak out a few more years of survival in the type 1 diabetics, the insulin-dependent diabetics,
Right.
was to put them on a very stringent diet. And actually, I had the opportunity to go to an exhibition. There was the centennial of the development of insulin in 1921. So it was 2021 at the New York Historical Society. And there I saw these very carefully written diaries of young kids and adolescents who were recording the minutia of their food intake. This amount of lard and this amount of butter and this amount of meat and vanishingly small carbohydrates, because that's what kept their blood sugar under control. They didn't thrive necessarily, because you without any production of insulin, you don't do that well. But it was what sustained them, and then then it changed.
Yeah, what's interesting is towards the end of the 19th century, the patients would show up in the hospital, whether they had type 1 or type 2, they would show up at the physician's office, usually after losing a significant amount of weight, and they're hungry all the time, they're thirsty all the time, they're peeing all the time. These were they're weak, emaciated. So part of the theory was, since they're showing up emaciated, you want to put as much weight back on them as you can. So you want to feed them as many calories as you can. So those are the constraints. No carbohydrates, maximum calories. And what you were giving them then were very high fat calories. Cream and butter were two things that patients with diabetes had to learn. And this was the therapy, again, for both type 1 and type 2. Because even though they recognized that these were kind of different diseases, the patients were different. By the time they showed up in the hospital, the manifestations were very similar. But type 1 was in youth, and they would, as you know, would die anyway. Even with this diet, it would slow down the progression of the disease, and the older, heavier patients could be kept alive indefinitely.
Mm-hmm.
Insulin's discovered, you have a drug. And this is a very powerful drug. So the first problem is you create the disorder known as hypoglycemia. It didn't exist until insulin was discovered. So very low blood pressure can also be fatal.
Blood sugar.
So now you had to, and insulin, they called it insulin overdose or insulin shock, and you could die from the therapy. So now you have to eat carbohydrates to cover the cure, the insulin that you're giving.
So in effect, your diet is chasing the medication. The medication, you have to kind of keep up with the insulin, because, that's why they recommend frequent carbohydrate snacks and keep, orange juice and crackers handy, just in case, et cetera, et cetera. That's been the standard way to approach patients on insulin.
And this all starts with insulin therapy. And the other factor is it starts with children, but physicians, a child might be diagnosed with type 1 diabetes at 7 or 8 or 10 years old, and it's a pretty heart-wrenching diagnosis. And back then it was a death sentence. And so they wanted to make the life of the child as easy as possible. So you don't want to say to this child, oh, A, you have this disease that's going to kill you within months to a few years, and B, we're not going to let you eat ice cream or cookies or crackers or pasta ever again. So once they had insulin, and allowed, they believed, children to eat whatever they wanted, and then you could cover their dietary sins with insulin. And once they accepted this approach for kids, it was natural to accept it for adults.
So let's distinguish now, and you do a beautiful job of doing this in the book, between type 1 and type 2 diabetes, where seemingly the endpoint of high blood sugar is the same, but the physiologic mechanisms are very different. And applying the insulin solution to both types of patients might be helpful for some, but disastrous for others, right?
And this is one of the points I make over and over in the book. Again, my initial interest in all these books is good science and bad science, how you establish reliable knowledge. And in the 1920s, when insulin was discovered, they know virtually nothing about this disease, other than in some cases, it's a disorder of insulin deficiency and the pancreas is involved. And those are the type 1 cases, and they represent, say, 5% of all cases, 1 out of every 20 individuals. They're the ones most likely to die quickly. They're the youngest, and they're the ones who are driving therapy. The doctors want to keep them alive. So many of the decisions about how to use insulin, who should get it, how much you should get, what kind of foods you should eat, are made to keep type 1 patients alive, when 19 out of 20 patients actually have a different disease. Not just, they're both insulin centric, but one is more of a disease of the liver than the pancreas. It's a disease of insulin resistance and too much insulin rather than too little. But it takes another 40 years before we learn that, because the technology didn't exist to study it. So the initial thinking about how to treat this disease once insulin therapy exists is based on the most severe patients who have a very different disease than 95% of their colleagues. Different organs, different approaches. The target is the same, keep blood sugar down. But in one case, the high blood sugar is caused by the absence of insulin. In the great majority of cases, it's caused by the resistance to the action of insulin, and you have too much insulin, not too little. All of this is ignored because the physicians at the time simply are unaware of it. They don't have the technology necessary they can't even measure blood sugar for all. They're measuring the sugar in the urine. It spills out into the urine.
They used to taste it, and then they had methods of testing in the urine.
Yeah,
that was
originally, or
the old-fashioned way.
Would taste it ideally.
Okay. I can't get my assistants to do that. No, I'm sorry. Okay, folks, at this point, let's pause and allow one of our sponsors an opportunity to share an important message with you. Here goes.
Kids don't just bring home homework, they bring home germs. And those germs don't just stay with them, they spread to the whole household. That's why Clear Nasal Spray was created by a practicing physician to give parents and grandparents peace of mind. You may not think about it, but your nose is filtering out a semi-truck full of air every single day. Clear isn't just another spray. It creates an additional layer of protection in your nose that blocks bacteria and viruses before they can even take hold. Yes, even that virus. Supporting your body's defenses right where germs first try to enter. Clear is a hygiene product recommended for daily use, drug-free, non-drowsy, and safe for all ages. Just a quick spray in the morning and evening helps you cleanse your nose. Don't just hope for protection, create it. Get Clear Nasal Spray, your daily defense. Clear Nasal Spray is available at retailers nationwide and online. Check out Xlear.com for our special offers. That's Xlear.com.
Thanks for listening. Thanks for supporting our sponsors. They, of course, are what make Intelligent Medicine continuing free resource to you with great guests like today's guest, Gary Taubes. The technology came into prominence, as you point out in the book, in the 1960s when a team, including Rosalind Yalow, who's actually a celebrated alumnus of my medical school, Albert Einstein College of Medicine, came up with something called RIA, radio immune assay. Yeah, so you can measure insulin. And then we discovered, lo and behold, that some people have an absence or negligible insulin. But paradoxically, the overweight, adult onset types of people with high blood sugar had too much insulin, very high insulin. So what happens when you mistakenly give someone with very high blood sugar who's overweight insulin? Is that to their benefit? I mean, you will lower their blood sugar. There's no question, right? So
yeah,
it's all good, right?
Well, you have to give them a lot of insulin because they're resistant to insulin already.
Yes.
So you have to give them very high doses of insulin. And one of the nuances of the physiology that these physicians, they should have known about it in this case, but they didn't, is that insulin also stimulates fat formation. So they know that obesity associates with diabetes. They know that the heavier you are, the more likely you are to become diabetic, and that diabetics are more likely to be obese than lean. By 1960, with this radioimmunoassay, they learned that obese patients and type 2 diabetics are insulin resistance, they have high levels of insulin and high blood sugar. So the insulin clearly isn't doing its job. And the insulin now, because you're treating high blood sugar, not the insulin itself. So in any other endocrinological, any other hormonal disorder, you treat the hormone level. Basically, if you've got too much thyroid hormone, and let's
give some thyroid,
adjust it so you have less. If you have too little, you give more. Here, you're not treating the level of the hormone, you're treating the level of the blood sugar. And so you're giving somebody who has too much insulin more insulin. Now, all of this would be fine if you get good results from these therapies. But going back in time again, by the 1930s, it's clear that these young patients who you're saving from imminent death with insulin therapy when they're 7, 10, or 12 years old, still dying tragically young, 10, 15, 20 years later from heart disease and their kidney failure, and they're going blind, and they've got neuropathy, and they're getting all these classic complications of the disorder. But the time that they're aware of that, they have no way to link it to, they don't know what's causing it. They assume it's poorly controlled blood sugar because that's how they're defining the disease. But all they really know is that it's poorly controlled blood sugar when it's controlled by insulin therapy. So it could be the insulin therapy that's causing this. It could be the blood sugar. It could be some combination of both. By the 1960s, as we realized that you're giving insulin therapy to patients who part of the problem is they have too much insulin in their blood already, you still have a disease that now is established to be a sort of chronic progressive disease. Everyone gets these side effects. They just have to, if they have the disease long enough, they'll get the kidney failure and the heart disease and the high blood pressure and the strokes and all these terrible consequences or complications of the disorder. So, because if you gave them these therapies, if you gave them insulin therapy, regardless of whether they had a deficiency of an insulin or an excess of insulin, and you didn't see the complications, and the patient went into remission or was completely under control, then that would be fine, but they're not.
Right.
And the diabetes community keeps doing these clinical trials demonstrating to them how deficient their approach is.
Well, they
have
also
no
did
awareness.
Not just insulin, but other therapies. Oral hypoglycemic medications have been around for quite some time as an alternative to insulin, especially for type 2 diabetics. Don't work in type 1 diabetics who need insulin. But they did these trials, the ENCORE trial, the ADVANCE trial. I read in your book that, and I've been aware, since these trials were performed, that these trials do not vindicate the notion that very aggressive blood sugar control is the key to extending life or reducing complications in diabetes. They were very disappointed in the result. They thought, great theory, let's keep the blood sugar really well controlled. Let's get hemoglobin A1C down to, near normal levels with very intensive therapy. Why didn't it work?
Well, and this is one of the fascinating parts of this history. So I give the diabetes research community an extraordinary amount of credit because I've also written, as you know, a lot about obesity, and these trials, these large randomized controlled trials have never really been done in obesity. But in diabetes, the diabetes community did these enormous, ambitious, expensive clinical trials to test their fundamental belief. So if you lower blood sugar by oral hypoglycemic agents, by pills, or by insulin, the patient will do better. That was the very first trial that was ever done in the 1960s.
Yeah.
And the result was the patients don't do any better than diet alone. The next study was, can we keep patients on only one drug and this was a British trial, and do our drugs basically prevent the progression of the disease? And that was a trial that demonstrated beyond a shadow of a doubt that this disease always seems to get worse. And then they had another trial, the diabetes complications and control trial, where intensive therapy in type 1 diabetics lower diabetic complications. And they did a little bit, and they said this is a great success, but they did it at the cost of increased hypoglycemic episodes. So it increased the burden of the disease on the patients. The patients got heavier. Then they did this series of trials, ADVANCE and ENCORE, testing the hypothesis that it's not just tight blood sugar control, but it's always tight blood sugar control by drugs, particularly by insulin. So whether intensive insulin therapy will prevent complications in type 2 diabetics, and lo and behold, the patients who are on intensive insulin therapy did worse, not better. The biggest of these trials, look ahead, $200 million. The fundamental assumption they're testing is that if a patient with diabetes can control their weight or lose some weight, that will delay complications and make them live longer. And after $200 million and like 8 years, the trial was stopped for futility because they were wrong. But they were always based on this assumption that we control blood sugar by drugs.
So
the net
result, Gary, and I'm seeing is that when diabetic patients come to me and I look at their hemoglobin A1C, it could be like, 7.5 or, 7.2. It's in the diabetic range, but their physicians, their endocrinologists, their diabetologists don't want to push it lower because they know that is not beneficial, but still they remain within the range of blood sugar where complications can occur over time and their lives are shortened. And they're told basically to follow the ADA diet recommendations or the American Heart Association diet recommendations, which are frankly demonizing fat. Fat being, cardiovascular disease, big problem in these patients. They say, well, my goodness, you do not want to be on lots of saturated fat, reduce your animal fat intake, have plenty of fresh, fruits and vegetables, the so-called DASH diet, grains, okay. The net result is poor control.
Well, so this is, and again, this is why I get into the history of all this. And this idea that dietary fat caused heart disease emerges in the 1950s, actually in the 19-teens in the diabetes world. It's never well supported by the evidence. In fact, there's significant evidence suggesting in diabetes it's just wrong. But as we buy into it, particularly here in the United States in the 1960s and 1970s, then launched these enormous government programs to convince the whole nation to go on low-fat diets. The idea, as you said, is that high-fat diets, particularly high-saturated fat diets, cause heart disease. And patients with diabetes have such a high risk, elevated risk of heart disease that you want to be as careful as possible. So we're going to put them on low-fat, low-saturated fat diets. And the ADA American Diabetes Association begins advising this in 1971. And suddenly they're telling patients with diabetes who have a disorder that doesn't allow them to metabolize the carbohydrate content of the diet safely, that they should get 50 to 60% of their calories from carbohydrates, from this one macronutrient that they need pharmaceuticals to metabolize. And it seems at the time perfectly reasonable because nobody says to themselves, wait a minute, these people can't metabolize carbohydrates and you're telling them that's the food they should eat. What's wrong with this picture? And that's why it takes, diet book doctors, people like you have been commenting on this. People like a journalist to come along 40 years later and say, what's wrong with this picture? Why are we sacrificing blood sugar control and requiring pharmaceutical use for a disorder that can be controlled by diet? And do we really think that the fat in the diet is going to kill more people than the uncontrolled blood sugar and all the consequences and complications of the various drug therapies that patients end up on?
So clearly we've taken a wrong turn. And has the position of the American Heart Association, or more particularly the American Diabetes Association, opened up the lens just a little bit to the potential for low-carb diets and ketogenic diets? I think the tide may be gradually turning, and I think largely due to a grassroots movement of which you can be proud to say that you spearheaded. I think you've really been at the tip of the spear of this movement to popularize low-carb diets. I mean, there are other figures like Dr. Atkins, of course, and others who have been crusading for this, but they at tremendous professional and personal cost, because they were lambasted as quacks, and that this is heretical.
It gets complicated. Certainly the people who first challenged it were either physicians like Atkins, in obesity primarily. And I mean, there was a whole world of physicians who kept advocating for low carbohydrate diets. The problem with them is they didn't have a lot of reach. And as soon as you start advocating for something that's so contrary to what the establishment, the conventional thinking, particularly in medicine, is disseminating, then you're considered a quack. You're risking people's health for personal gain. The best you can do is write a book.
Right.
And as soon as you write a book, they say you wrote the book because you want to get rich. It's all about finality. It's not about patient care. And then there are patients. One of the primary movers in all this, a man who should get extraordinary credit, is Richard Bernstein.
Who, by the way, here's a parenthetical note. Richard Bernstein was a classmate of mine at Albert Einstein College of Medicine. He was the oldest medical student in my class. By the time he entered medical school, he was 40. He'd already had a career as an engineer developing finger stick devices to check blood sugar. And then he decided to go to medical school. Or he worked on it.
Bernstein is diagnosed with diabetes.
He's diabetic.
1946.
Yeah, he's a type 1 diabetic.
He goes to Columbia as an undergraduate, studies engineering and physics. He ends up working for his father's medical device company, and then he's working in business, and he's still getting these medical device magazines. And he is slowly dying from type 1 diabetes. He's married, he's got 3 children. His life expectancy is maybe a decade. As he's manifesting various symptoms of poorly controlled diabetes, despite doing everything the ADA is recommending at the time. So he decides he's going to buy a blood sugar monitor that's being sold to hospitals, because the idea is if somebody appears in an emergency room on a Friday night and they're unconscious, you want to know were they hit by a pipe, did they pass out from alcohol, or are they in a diabetic coma? And you don't have time to send the blood out for a test. So bingo, here's these blood sugar monitors that had never been used by individual patients before. And Bernstein gets a version. His wife is a physician, so he gets one. She can get the company to send it to me. He works with one of the engineer salespeople at the company to figure out how best to do this. And over the course of a few years, he ends up testing his blood sugar, the first human to ever do this, first patient to test his blood sugar.
And parenthetically, I'll mention that he always used to sit in the front row of the lecture hall, and he would very ostentatiously check his blood sugar seemingly every couple of hours, so he would know exactly, because he believed in low-dose insulin administered frequently to cover, high or low blood sugar. So he was just, he stuck out like a sore thumb. And I have to say, I debated him. We had a nutrition study club at the time, and at the time I was a macrobiotic vegan, and I got to say I was on the wrong side of that argument, I confess. I would debate him about his high-fat, high-protein diet, and ultimately, I think he's been vindicated, because to my knowledge, he's got to be pushing 80. He's still alive.
He's turning 90 in a few months.
Goodness gracious.
And he's still practicing medicine.
I know. He's got the fire in the belly to take care of people and get the word out about his approach. And I think he's revolutionized this.
Well, and the point I make in the book is, let me just finish the story briefly.
Sure. Go.
Testing his blood sugar 7-8 times a day, after meals, after exercise, waking up, going to sleep. And he realizes with this very systematic experimental test that he cannot keep his blood sugar stable if he eats carbohydrates. It's pretty much that simple. He kind of buys into the dietary fat theory, so hence the high protein versus high fat. He's not a fan of ketogenic diets because of the sort of general zeitgeist of the time more than anything else. But he ends up demonstrating on himself that he can keep offensively healthy levels of blood sugar, not just not too high, but stable, just like a healthy individual, by a program that uses the smallest doses of insulin to cover minimal carbohydrate consumption. He's into networking. This is something he prides himself on. So he basically networks through the diabetes community, joins the Juvenile Diabetes Foundation committee that gives out awards, so he can meet the people who are being awarded. That New York is a hotbed of diabetes research at the time. He meets the head of the diabetes program at SUNY Downstate and at Columbia and at Rockefeller, and he says, look, I can keep my blood sugar stable, something they never thought was possible. So they start doing research on it, and then they host symposiums because they're demonstrating that using Bernstein's program, you can keep stable blood sugar in a type 1 diabetic. Again, never believed possible. And they motivate the government to do this large diabetes complications and control trial. And the government, the diabetes establishment, will not put diabetic patients on a low carbohydrate diet because it's still their belief system, and the ADA is saying they have to eat high carb, low fat diets. So the trial that is motivated by Bernstein's program becomes a trial only of insulin therapy, and intensive insulin therapy, and blood sugar monitoring, and insulin pumps, and everything that you can sell. Mm-hmm. But they leave diet out of it. The patients in this
they
trial,
could get behind his frequent testing approach, but not his dietary approach. They left that on the cutting room floor.
Yeah, so he did indeed spark this revolution. He should get credit for much. He single-handedly advanced the field of diabetes by probably 10 to 15 years because diabetes specialists didn't want their patients to measure blood sugar. Their patients measured their blood sugar themselves. They might never come in to see their physicians. So this was the last thing they wanted. But he couldn't catalyze enough of a revolution. He could not get the experts to think that maybe their dietary approach was wrong. Maybe a diet where you just don't eat the foods you can metabolize safely is better than a diet where you do eat it and use drugs to fix it. Yeah.
All right, good point at which to pause, because I think we laid down the central thesis of your new book, Rethinking Diabetes, What Science Reveals About Diet, Insulin, and Successful Treatments. It's a great book. I recommend it highly, not just to diabetics, but to people who are thinking about optimizing their health, because there's a preventive aspect to this as well. Gary, let's pause, and when we return, more on the subject of diet and diabetes, and diet and obesity, which is closely intertwined with blood sugar abnormalities. I'm Dr. Ronald Hoffman, and this is the Intelligent Medicine Podcast.